DAPT was one of the long-awaited clinical trials. We had data that was presented at AHA, now some additional data presented here at the ACC meeting in San Diego. So we had to pull together a conversation here with Dr. Robert Yee, who is an MD, MBA, co-director of Massachusetts General Hospital's Chronic Total Occlusion Intervention Program and associate director there of the Cardiac Intensive Care Unit, and also medical director of trial design at Harvard Clinical Research Institute. People were waiting for DAPT. I mean, this was a controversial area, and they really wanted to see what was happening. That data was presented at AHA. Just remind us again what was presented from that important paper.
Sure. The DAPT study compared 12 versus 30 months of dual antiplatelet therapy with aspirin and ethionopyridine in patients who underwent coronary stent procedures. And what the major findings were is that patients who were randomized to continued ethionopyridine had significant reductions, 70% reduction in stent thrombosis, as well as nearly 30% reductions in major adverse cardiovascular and cerebrovascular events with continued ethionopyridine therapy versus placebo. It was counterbalanced by an increase in bleeding. But the net result, we thought, was that the suggestion was of greater benefit for continuation of ethionopyridine in a rather all-comers population for patients who had first survived 12 months of therapy without having a major event.
Now here you've got some additional data that's being presented, and it is also being simultaneously published in JACC. So by the time they see this interview, they will probably be able to go online and just look at it. What's the data?
What we wanted to look at is whether or not the effects that we saw of continued ethionopyridine in the overall study population in DAPT were consistent among patients presenting with versus without acute coronary syndromes. So what we found here was that, in fact, the ischemic benefits, the reduction in stent thrombosis and myocardial infarction, were observed significantly in both the ACS population and the non-ACS population. The bleeding effect, we know it's counterbalanced by bleeding. There was a similar consistent bleeding impact of continued ethionopyridine therapy in both groups as well.
Now the whole concept of dual antiplatelet therapy has been how long is optimal? Mm-hmm. And there have been a variety of studies with a variety of time endpoints that look at just what should be recommended. After DAPT, where do you think we are in making recommendations?
Yeah, I'll say this, that although that there have been a number of trials that have compared different durations of dual antiplatelet therapy, the DAPT study is the sole study that was powered to address the ischemic endpoints. These ischemic endpoints are rare, stent thrombosis, myocardial infarction, but they are potentially catastrophic. Inadequately powered clinical trials are not able to gain inferences about the effect of dual antiplatelet therapy on those endpoints. So I think DAPT right now, in my opinion, is the sole trial that can inform that decision to talk about the potential benefits. And it showed potential benefits, significant benefits, on average in everybody who was enrolled, including non-ACS and ACS patients. So I think where we are now is, my personal practice is that in patients who have survived a year of dual antiplatelet therapy after coronary stent procedures, and they're tolerating it well, they haven't had a major bleed, we think that continuing ethionopyridine makes sense based on the data.
For which patients do you recognize they are having a harder time with it? They've made it to a year, but maybe they're about to hear in terms of carrying it forward. How do you talk to these patients and decide, this is the option that you have, do you want it?
Yeah, I think that what we've learned from DAPT and now the Pegasus Trial also presented here is that there's no free lunch. I mean, when one reduces ischemic endpoints, that's almost always invariably counterbalanced by an increase in bleeding endpoints. How do we balance those things? We've done a decision analysis in our group and looking at how does it impact patient quality of life, the ischemic endpoints and the bleeding endpoints? And we found that really these smaller reductions in ischemic endpoints could counterbalance a greater increase in what is usually moderate, non-life-threatening bleeding. And so we think that patients should be counseled, as you're suggesting, certainly, on both the risks and the benefits of it. They may bring their personal preferences into play about what they sort of value more, how impactful it is to take the therapy in terms of impacting their quality of life, a daily medication. But they need to understand the full, complete data of both the benefits and the risks.
But the clinician now is standing at a more solid ground when he's saying, this is good if we can continue it.
I think that's right. I mean, I think this is the first data that can randomize data that can really back a clinician in making that decision. And they do have now a body of evidence to support that clinical decision going forward.
Now, this is a JACC simultaneous publication, so it should be there by now from ACC 2015 in San Diego, California. I'm Executive Editor Rick McGuire.